Okay, last one. So sad. We've come full circle. So again, last thing is just remember that I'm going to be sending out, I know, but remember I'm going to be sending out a PowerPoint with all the questions in it. So don't waste time doing that. You guys study. Um, Jaylyn put in your group, or she put somewhere, the like an OMM study guide that I had made for this exam 3 years ago now, 2 years ago. Um, it's pretty much just like all of the LIs and then like little notes about everything, just so it's like all in one place. There are some OMM questions in this. I didn't do any like actual content because that's like, it's you're still very far out. But just to remind you guys like about some OMM, we're gonna do some questions today. But okay, so first so I went back in like some of my notes to see like what were some things that I wanted to highlight. So there's one thing on lymphatic drainage that I wanted to like review today. So here is kind of like the first aid page on the lymphatic drainage. This is kind of what I said was good to know in terms of like which lymph nodes are draining which parts of the body. That's still true, like definitely know this. But what I wanted to highlight was these guys down here. So I found this image and I put it down here. But it's basically like, so it's about if you have a lesion of your foot. It's really weird. I know it's like a foot, but like it actually comes up more than you would think because it's like an anatomy question. So let me show you what I mean. So if you have a medial foot lesion, so a medial foot, so imagine near your medial malleolus, somewhere over there. It actually bypasses the popliteal lymph node. So that's why if you notice on here, the popliteal lymph node only drains the dorsolateral foot and the posterior calf. It does not drain your medial foot. Super weird. So if you notice on this image, so this is like the medial, this would be like your medial foot, like the pathway it would follow. So let's say you have a tumor down here. It completely bypasses the popliteal lymph node and it goes right to the inguinal lymph node. Okay, it's just like a weird thing. Okay, so not all of the foot lesions get drained by the popliteal. If you have a lesion to the lateral foot, it goes first to the popliteal, so that's this one here. It goes first to the popliteal, and then it also goes to the inguinal. So it's kind of like medial versus lateral. Like medial bypasses the popliteal, lateral goes to the popliteal, and then to the inguinal. And then the other one I wanted to mention was so the superficial inguinal, if you guys remember from repro, that would be like the more superficial reproductive organ. So an example is like the glans penis. But also the skin of the posterior calf, super weird. So the skin of the posterior calf, I don't think I have it on this image, but it bypasses that and it goes directly to the deep inguinal nodes. So also kind of like this one. Just a weird thing I've noticed doing questions. I went back, like, obviously, I was like annotating first aid when I was studying for board. So, this is one of the things that I had annotated with lymphatic drainage. So, it comes up. So, it's just something I wanted you to be aware of. It's like super weird. That's why the posterior calf, it like goes to the popliteal and then it goes to the deep inguinal nodes. So, it kind of follows like that same pathway as the lateral, if you have like a lateral foot lesion. Okay. So that's just one weird like lymphatic drainage thing. Hopefully this makes sense. I think the images are really helpful to see with that. But okay. So I wanted to go back over transplant rejection. Someone actually asked if we could, and I actually drew like little images this time, hopefully to help, and I tried to color coordinate it. So there's four what is it? There's four transplant rejections. I think transplant rejections are super difficult. So in with this, so the first one's hyperacute. So hyperacute tells you how quickly it's happening. It's happening within minutes. Type 2 hypersensitivity, so that you know it's going to be an antibody against some sort of antigen. That's type 2 hypersensitivities. That's what happens. So remember though, with these type 2 hypersensitivities, these antibodies are going to be in the recipient. So the recipient I drew in green. And this would mean that the patient had to have had a transfusion in the past. They had to have had a sensitization event because antibodies are involved. So usually look for in your question stems like this is like a second transfusion or like a few like one that they've already had one in the past. It's not like their first time ever being transfused. So the recipient antibodies are going to be against the donor antigens. And then the only way to kind of treat this is to take out the graft. Acute, this can happen weeks to months. It kind of varies in time. It's a type 4 hypersensitivity. So with this color coding, think of this, since it's type 4, this is going to be T cells are going to be involved. So this is going to be both your CD8 and CD4 T cells against donor MHC. So here, like if we have a CD8 T cell being involved here, MHC1 and MHC2 can present these self-antigens from the organ to the CD8 positive T cell, and that would cause a reaction. And then here, the donor antigen presenting cell is presenting antigen to the recipient's T cells. It's super weird. It's like you have like a disconnect. So that's your type 4. Chronic, remember I said that chronic happens to like every single organ. Like every single organ that you transplant is going to eventually have like a chronic rejection. So it has qualities of both type 2 and type 4, but mainly with chronic, you're thinking like humoral, like the antibodies are the ones kind of doing the issue, like causing the issues, which I put up here. Again, happens months to years. Every single kind of transplant goes through this. But the recipient, so it's kind of the exact opposite of this. It's like with this one, it's like the donor MHCs are presenting to the recipient T cells. This is now like the recipient's MHCs are presenting to the recipient T cells, but they're presenting donor peptides. And again, just think of like if you transplant an organ into anyone that's not yourself, like if you give anyone an organ, even if you put these people on immunosuppressants, like they know it's not going to be like a perfect 100% match. Even if it's like an identical twin, like they should be like identical, but there's a lot of stuff that goes into like the genetics it's not going to be like a beautiful, perfect match. So this is like your typical, what you would think of a transplant rejection. The recipient is presenting the donor peptides to the recipient's immune system. So you can see humoral immunity. So here's your recipient antigen presenting cell. It takes portions of like the donor liver, presenting it to a CD4 positive T cell, which can activate B cells. And now these antibodies that they're making are going to be then donor antibodies. And then those go and attack the donor organ, and yeah. And you can also have, and then also here you can get the class switching, yeah, what we just kind of talked about. So T cells are kind of involved in that way. That's why it has like type 4 in the name, because T cells are activating the B cells to make the antibodies, but mainly the issue is because of these antibodies. They're going back and attacking the donor organ. Okay, and then the last one, this was the cool one. This is where the organ is rejecting the host. So type 4, T cells are involved. Again, remember it's going to vary in time. Don't use that as kind of like a way to differentiate. But this is where the donor T cells that came with the organ are rejecting the body. So just visually kind of seeing it, here's like donor T cells that they just came along with the organ, and now they're attacking the recipient cells. It's like the exact opposite of chronic. Okay. So those are your transplant rejections. Really try to, I did bring in some questions today where we're going to talk about just how you can kind of recognize them in question prompts. But these always come up. These are like very clinical type stuff. So these are always going to come up with anything immuno. And then transfusion reactions, same kind of concept with these. I didn't change much. Oh, sorry. Let me pull up the chat. Can any of these reactions happen with any organ, blood in theory? Good question. So usually the transplant rejections are solid organs, something that's going to like bring along with it T cells, and something that's going to bring along with it like these nice peptides that are conserved. Blood is, if you have like a reaction with blood, it's more so going to be, I think the next one, it's more so going to be this. It's more so going to be like an acute hemolytic or one of these transfusion reactions. But blood is an organ, so that's a good question. But usually the transplant rejections think solid organs. Okay, so for this, I just kind of like changed up. So I tried to keep the same coloration like last time. It's pretty much the same as when I presented it last time, but I highlighted the symptoms because this is what you're going to want to look for in your question stem. And then, because a lot of the times what they're going to do is they're going to give you a vignette and you have to identify what type of transfusion reaction they're talking about. But then they're going to ask you something about like the aspect, like something that would be on this list. So like what type of hypersensitivity is it? What antibodies mediating damage? What specifically is happening? Like something like that. So this is how you kind of figure out what it is. But then you have to kind of use your knowledge to answer, like use one of these to answer the actual question. So again, very briefly, there are 5 of these. So the first one, allergic anaphylactic. This is, think of it as just like being with allergies. So it's going to be type 1 hypersensitivity, IgE mediated, happens super, super quickly. Clearly, there is a pre-sensitization event. So that would usually also be in the prompt. And what happens here is it's the recipient's mast cells are degranulating due to the donor's plasma proteins. It's kind of like allergies, right? So like instead of being a donor, it would just be like a foreign antigen causes the recipient's mast cells to degranulate. But the ones that always happen, and this was actually a question I brought in yesterday, I think, selective IgA deficiency. You don't know you have it, you get a transfusion, sensitizes you, next transfusion, you get mast cell degranulation. And how it's going to look is all the symptoms that would be like IgE mediated. So fever, wheezing, urticaria, so like itching and hives and whatnot. But wheezing is the big one because remember that trolley, which we're going to talk about, that's the lung one. That is lungs, but it's not wheezing. Wheezing is not a symptom for trolley. So just keep that in mind. Wheezing is for the allergic anaphylactic one. Again, just think of like an anaphylactic reaction. So on this image, like we kind of talked about the last time, we have our mast cell with the IgE on the top. The IgE, specifically, it's confusing because it's anti-IgA, IgE, but it's just saying like, and so again, this was created from a previous transfusion, implanted into the mast cell. Now you get the second transfusion, IgA is there, degranulation. So that's going to kind of stimulate the degranulation aspect of it. Okay. Acute hemolytic, this would be more so for like your, like think blood transfusions and it's like something went wrong with that blood transfusion. That would be acute hemolytic. There's another one. I think it's actually there's another one. We'll get to it. There's like 2 main ones for like blood stuff. The acute hemolytic, this is like bad, like someone messed up basically. Like someone in the blood bank lab messed up. They gave the wrong unit of blood to, like, if you're type A, you got type B. That's acute hemolytic. It's really bad. So this is IgG mediated. It's type 2 hypersensitivity because again, it's an antibody to an antigen. So it would be like anti-A antibody against the A antigen on the red cells. This usually happens during the transfusion. So you can actively see this happening during the transfusion. Like you can see the patient getting like these symptoms or within 24 hours. It doesn't have to be like exactly afterwards. Like they can go home and then they can start having these symptoms. So kind of keeping that color coding, it's the recipient has these preformed antibodies against the donor's red cells. Again, just think of a type A patient receiving type B blood. Remember with this, you don't need a pre-sensitization event because remember, if you're type B, you automatically make anti-A. So that's why this is even worse because it's like, well, how many times do these lab people make mistakes, right? Like how many times does that happen? It's not going to happen twice to the same patient. It doesn't have to if it's blood because remember, they make preformed, well, not preformed, sorry, they automatically make the antibody against the other blood type. Except with D antigen. Remember, D antigen's a little different. But at least with this would cause an acute hemolytic reaction. And what this would look like, look for these in the question stem somewhere. Blood in the urine, like hematuria, flank pain, like they have low back pain, something like that. It's just to say because like within red blood cells, I don't know exactly how far into this you guys have gone. Maybe not. I think this is more of a second year thing. But within red blood cells, there's all sorts of stuff. So when they kind of burst open, which is what's happening here, the kidneys have to filter that. And there's some byproducts in there that are really toxic to kidneys. So that's where you get the flank pain and the kidneys can't filter the blood. So you get blood in urine. So that's kind of what's happening here. Yeah, and then there's the picture from first aid. So febrile non-hemo... Oh. Okay, so no silly question. Okay, is the patient's own blood the new blood or all of the blood lysing? So it would be the patient's blood. That's a good question. Actually, oh, that's a good question. I think all of it would, right? Because the patient is type A, automatically has anti-B in its body. The blood coming in automatically has anti-A. I think all the blood is lysing. That's a really good question. Yeah, so that's why, yeah, this one's really bad. Like, that's what I'm saying. Like, this type of mistake is super, super bad. So, like, you can imagine, like, the patient, it's going to be bad. Like, there's going to be blood everywhere because all the blood is lysing. Yeah, that's kind of cool. I didn't even think about that. You're right. So, it's like the patient's blood and the donor's blood is all, like, everything's lysing. But the issue obviously is the patient's blood lysing. Like that's the issue. That's what the organs kind of are relying on, like without the new blood coming in. Okay, so for this one, I kind of added a little bit more because I think this one's kind of hard to visualize, at least with the first aid picture. But remember, febrile non-hemolytic, this kind of tells you in the like what type of transfusion reaction it's going to be, like it's in the name. So they're going to have a fever, and you're not having a hemolytic reaction. So you're not having something like this. You're not having like blood in the urine, flying pain. That's not happening. And remember, this is the one that happens where if you don't irradiate, actually, did I take it out of here? I think I might have. Oh no, it's right here. If you don't irradiate blood before you give it to a patient, what can happen is the donor's white cells, like the neutrophils within the donor blood bag, during storage, it's just sitting in the fridge. They just start making cytokines. It just happens. And usually you irradiate the blood and that gets rid of these cytokines. But in this instance, you forgot, or you just didn't do it, or you didn't do it soon enough before the transfusion. So this can happen anywhere within 1 to 6 hours after, but what's going to happen is within that same day, it's going to be that same day, the patient's going to have a fever and chills. So fever, febrile, and chills, but no hemolysis is happening. It's not like this. So there's two mechanisms. So it's kind of like what we talked about. This is the one from first aid where it's kind of like the donor white blood cells release these preformed cytokines, and a lot of the times they're inflammatory cytokines. So like IL-6, TNF alpha, IL-1, they're accumulating. So if you give it to a patient, they're going to cause fever, right? Because these are ones that are pro-inflammatory cytokines. So you give basically a blood bag of pro-inflammatory cytokines, you're going to see symptoms of pro-inflammatory cytokine release in the recipient, which is like fever and chills. I think I put this one in here because someone last year found a question where there's like another mechanism against febrile non-hemolytic. So I think I put it in here, but just know that this is like the more common. That's why I put the star here. It's the more common one. But I think, again, I added this because it was like in a question last year. It would just be like the recipient. So the person receiving the blood makes antibodies against the donor's MHC. So when that happens, it's triggering it's inflammatory, right? So it's going to be an antibody binding to like an antigen. You get an inflammatory response, but it's going to present the same way. Okay. Second to last, so this is Charlie. So this is going to be the same day as transfusion again. It can be within minutes to 6 hours post-transfusion. It's always kind of hard to tell with the timing. But this is the recipient's neutrophils. So the recipient's neutrophils in the lungs get activated by the donor's anti-white blood cell antibodies. So the donor, for whatever reason, has these like leukocyte, so anti-white blood cell IgG, binds to the neutrophil, activates it. Now you get like symptoms of like neutrophil degranulation in the lungs. So how would that present? It would present with like lung symptoms. So cough, pulmonary edema, shortness of breath. Again, these are all symptoms of like a lung thing. That's kind of what you're looking for. If you do a chest x-ray, you would kind of see some pulmonary edema. You would kind of see like the shunting, like the throwback to pulm, right? You would kind of see like the shunting of some of the vessels. But again, not wheezing on here. There's absolutely no wheezing with Charlie. Wheezing is an allergic reaction. It's not a lung injury. Okay. And then lastly, we have our delayed. Remember, it's delayed, so timing is going to be key with this. This is the only one that doesn't happen on the same day. So if you go back, I even say like, okay, it's in the same day, 6 hours, like within 24 hours. So within the same day from the time of the transfusion, immediate. So like all of these are happening within the same day. This is the only one that doesn't. So that's literally one of the best ways to identify this type of transfusion reaction. And what happens here is the recipient's antibodies, so the recipient makes antibodies against donor red cells. This is usually, so remember how this kind of sounds the same, right, as this one? Kind of sounds the same. It's the recipient's antibodies against donor red cells, but this one's really bad because remember, again, think like a type A person receiving type B blood. Really bad. Those are major antigens that are present on the surface of the red cell. This is usually like minor antigens, like minor. So when you do cross matches, you do like a major cross match and a minor cross match. If you just do a major cross match, you would miss this. And the minor cross match is detecting like these other antigens, like these other random antigens that would be present on the surface of the red cell. So if you don't do that, you miss some of these other minor antigens, and then you get this delayed transfusion reaction. But it's delayed because they need time to make antibodies against it. because they're seeing it for the first time. So this is what you're going to look for in your question stem: onset of anemia, because again, now we're antibodies against antigens on red cells. We're going to lyse the red cell, but it's happening 1 to 2 weeks after the transfusion. So then on here, this is what was in the notes from last time. So again, you can use this. I also put this in here. This was also something that I had added to my notes to kind of show the timeline, to kind of show like if you kind of like to visualize it this way, and then the type of hypersensitivity. So we got allergic as your type 1. So IgE mediated. You're going to see you need prior exposure for this, obviously, because that's how it happens so quickly. Most common example of it, and how you treat it. So you actually treat the allergic transfusion reaction. You have to stop the transfusion, obviously, but then you give the patient antihistamines because it's literally a mast cell degranulation issue. Within 1 to 6 hours, but really the same day. Like all of these are happening within the same day. You can get two type 2 hypersensitivities. So the febrile non-hemolytic, remember that's your stored cytokines. That's the more common one. And you just get those symptoms of fever, chills, but no hemolysis. Or you get the hemolysis one. So this is you give the wrong antibody. Sorry, the wrong blood to the patient with the different blood type. So flank pain, jaundice, anything that would suggest like there's massive hemolysis happening. So jaundice, I don't know if you guys did that in GI this year. I can't remember when we learned about the types of jaundice. But one of the things that can cause jaundice is just massive. It's like your pre-hepatic jaundice, right? Just massive hemolysis of red cells. So it doesn't have to just be kidney stuff, but like these are like little things to look for. Trolley, this is your lung one. And remember, it's the donor had pre-made these antibodies against recipient neutrophils. And it's the donor. This is like, I guess I highlighted this because I got a question wrong in it or something, but I don't know why I underlined it and made it all caps. It was like I was yelling at myself. But look for your symptoms of lung disease. So pulmonary edema, not wheezing, coughing, shortness of breath, things like that. And then last, delayed. So this would be days to weeks later, so not happening on the same day. So you can kind of draw it like this. But it's delayed, but it's not considered a type 4. So that's also something to kind of mention. It's not considered type 4 because T cells are not involved. It's more of like, it's kind of the same idea as the hemolytic. It's just happening much later because you need time to make the antibodies. So it is a hemolytic one. So it is hemolytic. You're going to see kind of the same symptoms. You'd see a positive Coombs test. So remember the Coombs test? Remember that guy? Because remember and this would be a direct Coombs test. And remember, the direct Coombs test is trying to see, is there something coating my red cells? Is there like an antibody there that's binding to an antigen on my red cells? So you'd see a positive Coombs test. That'd be like, yeah. And remember, I told you kind of think of your direct Coombs test as being like is there a type 2 hypersensitivity here? Whereas indirect is more so like, did someone that shouldn't be making an antibody, are they making that antibody? And so this is kind of like this would be and what I'm kind of writing here is like, this would happen with like an RH type thing. Like if you give an RH blood to someone, they're going to make anti-RH. But again, it's going to take time for them to do this. It can be clinically silent. It can be because until it actually starts happening. If it's not clinically silent, you're going to see those symptoms of anemia. And again, it's just going to depend on how many antibodies they're making, how many times were they exposed to this, is this their first exposure? So just little things to look out for. I think the best way to kind of nail these is questions. But yeah, okay. So transfusion reactions, transplant rejections, great. Okay, questions. So do you guys have any questions about that? Anything I just mentioned? Because if not, we're going to kind of just go over questions for like everything. But particularly things I really wanted you guys to get out of this. And there might be questions on here that you've already seen. It's just ones that I really think are important to know. Okay. All right, let's get after it. Set my timer. Okay, 90 seconds. Okay, so I like this question a lot. This is kind of like showing like, hey, your anatomy and your knowledge of pathology like kind of coming together. So this, you kind of had to identify what type, what immunodeficiency this is. So if you guys remember the mnemonic catch-22, this is going to be your DiGeorge syndrome. Remember the 22 for chromosome 22. You see like what are they called? They're called something facies. It's just like weird facial symptoms, cardiac defects, hypocalcemia, all sorts of stuff like that. And then if you remember, now you're like, all right, this is DiGeorge. What type of issues with DiGeorge? T cells. T cells are affected. What part of the lymph node will be underdeveloped? The paracortex. This was a very, very board style question. So great job if you guys got this one. If you got this one. Again, I know you guys are like a week out from your exam. Remember last year when I came up with these, like when I brought these in, they were like 3 days out from their exam. So I was like, you guys better get these. But you guys have like a week and a half. Well, a week. Yeah, like a week and a half. But so if you didn't get it, it's okay. But I just like that's the kind of reasoning that they're going to do with Immuno. Awesome. And then this will be posted and you can review it on your own. Okay, next. Okay, that was 90. How you guys doing? All right. Okay. Let's review MHC1 versus MHC2, shall we? So this is really important. Remember I mentioned kind of like remember your little this is a lot of answer choices. I'll give you that. This is way too many like you would see on your exam, but it's really important to understand the differences between 1 and 2. So with this one, again, kind of the same idea as the last one. You kind of have to identify which one is this. Is this MHC1 or MHC2 are they talking about? So if you look at the question, they're talking about how this patient has an RNA virus. So there's a viral infection. So it's saying like, okay, certain cells present antigens from the pathogen to a CD8 positive T cell. So remember the rule of 8. So this would be an MHC class 1. So remember MHC class 1 times 8 is 8. MHC class 2 times 4 is 8. So that's your rule of 8. So they're talking about MHC class 1. So then coming down here, which of these is true or false about MHC class 1? Which one is true about MHC class 1? So if you're looking, okay, so antigens are loaded into the molecule within lysosomes. Remember with MHC class 1, they're loading endogenous antigens, so they're not messing with the lysosomes. They're getting loaded as soon as they're made. They're actually getting loaded in the ER. So second one, molecule consists of a heavy chain associated with beta-2 microglobulin. This is correct, but let's just say, oh, that sounds correct. Let's go to the next one. So the molecule is made up of 2 chains of equal length. No, remember MHC class 2, 2 for 2 chains of equal length. Remember, this is what MHC class 1 has. It has a heavy chain, and then it has that beta-2 microglobulin non-covalently associated with it. Molecules goes for presentation of exogenously synthesized antigens. Endogenously, we just talked about that. Think viral infections. Molecule induces activation of the humoral immune response. So remember with the humoral immune response, this would be like B cells, B cell activation, B cells releasing antibodies. That's more of like your MHC class 2 type of thing. So this molecule doesn't do that. This molecule is selectively expressed by APCs. MHC class 2. Remember, that's the 3 APCs, dendritic cells, macrophages, and B cells. And then remember with MHC class 1s, all of the HLA genes are one letter. So MHC class 1 for one letter. So it's actually going to be A, B, and C. DP, DQ, and DR are for MHC class 2. So this one is B. And we just went through why all the other ones are wrong. And then here's like a picture from first aid. Again, it's not first aid, from AMBOSS, showing kind of like the structural differences between the two. And yeah, and then you just have to remember those other associations. Like remember, class 1 is loaded by TAP in the rough ER. Class 2 usually has like that invariant chain in it, and then it's clipped off. And then when it's ready to be loaded with antigen, it's clipped off, and then the antigen's added there. This one's a lot more stable, trafficking to the surface than MHC class 1. Class 1's a little less stable, and that's why this one tends to get downregulated with like viral infections and cancers. Okay. Next. Yes, exactly. Sorry, I'm gonna actually, I'll just talk. You guys can do this if you want, though. Actually, no, sorry. I'm gonna go back because it's a good question. So is the invariant chain acting like a placeholder for the antigen? Exactly. You don't want self antigen to accidentally get loaded into MHC class 2. That would be very bad. So kind of what invariant chain is doing is it's kind of like preventing like self antigens from getting loaded. And then when you have the actual like exogenous antigen peptide, that gets loaded, and when that gets loaded, it causes the invariant chain to get like clipped off. It's a good question. Yeah, so that's kind of what the invariant chain is. It's like trying to prevent self peptide loading. There is something similar with MHC class 1. You guys just don't have to know it, but there's also something similar with that. Okay, now here's the question. Okay, that was about 90. So yeah, some of you guys picked up. Yes, I brought this one in before. I just think this is a really good question because it again ties in. It's kind of like the DeGeorge question. It ties in like your knowledge of like the anatomy with the physiology of what's happening there. So this one, they tell you it's a lymph node. Last time I told you like lymph node, I had it down here. But that's like a good, you should, I mean, yeah, so they tell you it's a lymph node. And then they're pointing to this part, this here. They're basically pointing to the center part of this. So if you guys remember, one of the things, the reason I brought this in one of the last times was to remind you guys that in a lymph node, it's not like the adrenal gland, it's not like the kidney. The cortex is not on the outside, and the medulla is not on the inside. That's kind of not what's happening in the lymph node. The cortex is just wherever the follicles are. So this is kind of saying like they're pointing at a follicle, and you can see follicles everywhere. Like there's some like more in the middle, there's some more on the outside, there's some out here. So remember that aspect of the lymph node, just wherever the follicles are, that's considered the cortex and the B cell zone. The paracortex is just everything around. So like all of this would just be considered paracortex, just everything in between all of the follicles. The medulla is, I think, still considered the middle. like the middle part, but it's kind of tricky with lymph nodes. And then these would be like the sinuses, like the where like the macrophages and whatnot are. But anyway, so this one, they're pointing to a follicle. That's your B cell zone. So this one, what happens in a follicle? Remember, that's where you get B cell activation, and that's also where you would get class switching. So remember that one image of the B cell going to like the dendritic, like the follicular dendritic cell in the follicle, seeing the antigen, and then kind of going back and forth to do isotype switching, somatic hypermutation, all that stuff. That's all happening in the follicle. VDJ recombination, this one only happens in the bone marrow. Remember, this is like before the B cell even leaves. Negative selection, this is your T cell negative selection. This is the thymus medulla, so that's occurring in the thymus medulla, so this is not even happening within the thing. If it's specifically talking about B cells, though, that would be still happening within the bone marrow. Macrophage activation, that happens outside in the periphery, and then it goes to the lymph node to go activate B and T cells. T cell activation would be outside. It would be in the paracortex. Okay. So if positive selection was an answer, would that be correct too, since that happens in the cortex? Yes. So if positive selection was here, that would also kind of be, actually, since positive selection happens in the cortex. So do you mean, so positive selection and negative selection for B cells is kind of like testing the B cell receptor when you're making it. So specifically with B cells, that would be in the bone marrow. So like positive and negative selection for B cells would all kind of be with like VDJ recombination, positive, negative selection. Because remember, you have to make the B cell receptor. Oh, for T cells. Good question. So positive selection for T cells happens in the cortex of the thymus. So that's why it's kind of good. Like they told you that this was a lymph node, and they wouldn't expect you like for first year to kind of look at this, be like, oh, it's a lymph node. They would have to tell you what this is. If this was a thymus, that's more so like the core. Yeah, it would be like the cortex of the thymus, which would be towards the like the outer portion a little bit more. Do B cells do anything else in the follicles or just isotype switching? So if other answer choices that would have made this correct would have been B cell activation, that would have also made this correct. So they had T cell activation, B cell activation would have been good. Isotype switching is obviously correct. Somatic hypermutation or affinity maturation, both of these would be correct. What else happens in the follicle? That's pretty much it. It's just kind of like, it's anything associated with like activating your B cell. And remember, when you activate your B cell with T cells, you get isotype switching, somatic hypermutation, affinity maturation. So those would have all been like answers here. No problem. Okay, so just a reminder, lymph node, follicle, like cortex, follicles, that's your B cell zone. That's where your B cells are getting activated. And then T cells in the lymph node, that's your paracortex, which is what they're not pointing at here. Positive, negative selection for T cells happens in the thymus, positive selection in the cortex, negative selection in the medulla. VDJ recombination is specifically talking about B cells. VDJ, that happens in the bone marrow. Positive and negative selection of B cells, they're specifically talking about that B cell receptor that also happens in the bone marrow. Remember, you want this to happen before it's allowed to leave the periphery. B cells are only made and they mature in the bone marrow. That's why they're called B cells, whereas T cells develop, like they finish their maturation in the thymus. So that's why the positive and negative selection happens in the thymus for the T cells. But activation can happen in the paracortex of these other secondary lymph node organs. Okay. I know, lots going on with this. Lots to keep lots to keep track of, honestly. So that's kind of what they're saying. And kind of the tie-in, I think I put this one in there last time, but kind of like the tie-in after now we've talked about the immunodeficiencies. This is kind of like where you would see no germinal centers. So like if you have a list, like where would you not see germinal centers with immunodeficiencies? It would be like Bruton's, hyper IgM, SCID. Those three, you wouldn't have germinal centers because you're not getting B cell activation at all. And remember, what are germinal centers? So here's the follicle. This is like a follicle that has B cells that have never been activated. Once you activate, so T-dependent B cell activation, so we're activating our B cells, You're still in the follicle, but now we get what's known as a secondary follicle, right? Which is the germinal center. So that's kind of why, so like that, this would be the germinal center. And this is kind of just where the center where B cells get activated. Whereas this, like, they could straight up just be like, okay, I don't see any non-secondary follicles on here. Let's pretend there's just one that's like a dark purple circle, like no lighter purple. Like, let me get rid of all this text. So see how this one is like a red, a purple, like a dark purple outline, and then on the inside it's like a lighter purple. This is an active so this is a secondary follicle. There's a germinal center in here. If you have one that's just completely one color, that has never been activated. You can't call that a germinal center. That's just a primary follicle, never been activated type of thing. Would you have germinal centers with CVID? CVID, that's probably not, but remember with CVID it happens like after puberty usually. So that would be more of the key with CVID, but yeah, you'd probably also not get you would also not have germinal centers. Because again, it's like the B cells are not getting activated correctly. And remember, like CVID, I always like think of it as like a less severe version of SCID. So it's T cells, it's B cells, they're just not really working. So yeah, you could also add that to the list for sure. It's just like with immunodeficiencies, when you're trying to like when they give you something like this, like the absence of germinal centers, they're trying to help you narrow it down to one of these like that you would see in like a 1-year-old. Okay. But yeah, I would say yeah, you probably won't have germinal centers with CVID. Haha. Had to do it. I'm sorry. Had to remind you guys that it exists. Okay, that was 90. I know I'm really making you guys go in the depths of your mind. But this one, so remember with your diaphragms, remember lymphatic, this isn't a bad one with anatomy for lymphatic, like for the immune system, because remember lymphatic fluid drains up. So for this, it's kind of like you have to like open up the parts closest to where the thoracic outlet is, where the thoracic duct is, and like the right lymphatic duct. So you start with whatever's closest to that, which would be the thoracic outlet. So okay, we're at C or E right now. And then you just go in order. So then you just go in order of what comes next. So what comes next? The respiratory diaphragm. Great. So we're still on C and E. All right, so C and E, they differ between pelvic and popliteal. Remember, the pelvic is where the pelvic bones are, so like your hips, basically. And then the popliteal, that's down in your leg. So this one would be C, because that's just going down the order, the proper order. Great job. My resident OMM people. Yes. So right leg comes before pelvis. The leg comes after, so the popliteal comes after the pelvis because you open it last because it's all the way down. We can talk about it. If you're still confused, we can talk about it later. But okay. And if you guys want, if you answer this fairly quickly, you can tell me what disorder this is too, just for extra practice. Okay, that was 90, but I'm going to give you guys a little bit more time with this one. Okay, you guys ready? I don't want to take away from these review questions if you guys want to keep going, but like one more time, just let me know. But we are going to go through this. All right, so we got a young girl, so that's okay. We're thinking like immunodeficiency, right? Brought in 1 week after admission, bacterial pneumonia. Okay, so she had some sort of bacterial thing. She's had recurrent episodes of otitis media, usually caused by a bacteria. Infectious diarrhea. Note, whenever they say infectious diarrhea, this is a bacteria causing diarrhea. So some sort of like bacterial infection causing diarrhea. Okay, so lots of bacterial stuff so far. She underwent treatment for oral thrush 1 month ago. What's thrush? Do you guys remember thrush? Thrush is a T cell thing. So now we have some B cell stuff happening. We got some bacterial infections. We got a T cell thing. We got some candida. Height and weight are both below 10th percentile. Sounds a little like a like failure to thrive here. No visible tonsils. Okay, that doesn't really help you with T or B cell stuff. Slightly decreased breath sounds, could have pneumonia. This is your key. Increased deoxyadenosine concentration. So there's increased deoxyadenosine, and then you have to remember like which of the one. Remember, there's one of these immunodeficiencies that causes an ADA deficiency, which is the enzyme that breaks this down. So we are missing the enzyme that breaks this down. So that's going to be increased in the serum and the urine. And boom, absinthymic shadow. We got T cell, we got B cell, we got ADA. This is SCID. So this is SCID. This is actually your classic. This is a very, that's why I put this one in the review and not in the immunodeficiency one whenever we did 2 days ago, because this is like a classic how SCID presents. You got B cell stuff happening, you got T cell stuff happening, and then they're going to give you something that's going to tell you like the genetics behind it. For this, it would be like an ADA deficiency causing increased deoxyadenosine. So then remember with SCID, it's decreased B and T cells, but the only option we have here is decreased T cells. Okay, so then remember from this, here's just the slide from when we did immunodeficiencies. So remember the bubble, these are your bubble kids and ADA deficiency. It's not as common, but it can also lead to SCID. And remember failure to thrive. Remember I kind of mentioned failure to thrive. Look for things that say like they're really small, like just like what are they saying here? Yeah, below 10th percentile in terms of height and weight. It's not always failure to thrive, but it kind of has you like maybe thinking about that. And then no thymus, no germinal centers, which this would present as like no lymph nodes, but also if they have no paracortex, that would also present as like no lymph nodes, no visible tonsils. This doesn't really help you. It's like you don't know if this is germinal centers or paracortex, but it's both in this. And then the thymic shadow for T cells.
Hey, I just have a question for you.
Yeah.
So, like, it seems like her symptoms started at 6 months, which is kind of what threw me off. Like,
Mhm.
I thought that the IgG really only lasts for like 6 weeks.
No, 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 6 months.
Oh, okay. Well, then that makes more sense. Thank you.
Yeah, no problem. Yeah, yeah, yeah. So 6 months. So you're good for 6 months. It can vary. It can be like from 6 months to a year. Um, I've seen like a lot of different variations. So around then though is when this all will start happening. Probably like no sooner than 6 months though. But you can see variation. Like it might say like, by 8 months, so it's 2 months later. That's fine. It's usually somewhere between 6 months to a year. You're protected from mom's antibodies. But up to a year, it's like fine because that's when the baby can start making their own antibodies about a year out. Yeah, very important clarification. 6 months, not 6 weeks. So that's good. All right. Good. Skid, Bubble Kids. Think of Seinfeld. Think of the Bubble Boy on Seinfeld. Okay. Haha. I'm sorry, guys. I'm having you lean into it though. Okay, does anyone want more time for this question? I just want you to know that I have votes for every single answer choice here. Which is good because you probably haven't thought of like post isometric relaxation in years, right? Okay. So remember with these questions for OMM, you want to diagnose the patient first, and you always diagnose their ease. Okay. So with this, if we're diagnosing the ease, okay, blah, 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 blah. Okay. Restriction and rotation to the right means, what does this mean? Restriction and rotation to the, oh my God. Restriction and rotation to the right. Where's the ease? Good. Okay, good. 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 So you guys are getting it. Good. So rotated left. So restriction and rotation to the right means they're rotated left. Okay? Then it worsens inflection and neutral. So if it's worsening inflection and neutral, then obviously it's going to be right, extended. So this is like her diagnose. Well, we can assume side bend left. Good. So you guys are saying good. So C7, E, side bent left, rotated left. I wrote it in a really strange order, but this is the diagnosis. So remember with post ISO, the initial this is also something you want to look for in these questions. The initial positioning versus which way do you want to tell the patient to push. Yeah, good. Okay. So remember if you're which way, so the initial positioning, so post isometric relaxation, you want to put them into their barrier. So you want to do everything exactly the opposite. So we want to rotate them right, we want to side bend them right, and we want to flex them. So that would be the initial positioning for this one. So this one would be D. But sometimes the question could be, what is the way that you tell the patient to push? That is the same as the diagnosis. So a lot of the times when I'm doing like these OMM questions, I write out the diagnosis. Under it, if it's post ISO, I'll do what's the barrier, and then I just kind of remind myself like which way do I tell the patient to push? It would be the same as their diagnosis, and you always, always, always diagnose the ease. Okay? It's fine. It's fine. You got like a week and a half to review OMM, but good. Okay, just throwing these in here. Okay, that was 90. I think a lot of you guys have answered, but again, let me know if you need more time, of course. But this is basically just saying you could have even not even read the question and just been like, there's one of these that's wrong. The other ones are all correct. Like that can be done. So this one is this one is going to be B. So you can't give so so the RH matches and that's fine, but you cannot give A blood to a B person. Remember, like this is the hemolytic one. This can happen like as soon as this can start happening as soon as you're transfusing the patient. Doesn't always, but it's going to be bad because remember the patient already makes this patient is already going to make anti-A. There's no sensitization there's no sensitization event needed whatsoever for A and B. RH, there is. But with this, it can happen ASAP. What if A read backwards, ORH positive to ORH negative? Is that more immediate? No, it's not. And it's because, remember, if you're O negative, you don't automatically make O positive. You don't automatically make anti-D or anti-RH. That would be such an issue, right, for the RH negative moms with their RH positive babies. That would be really bad for that. You would eventually that would be more of like the one that like takes a little bit longer to happen. So that would take a little bit longer for it to happen. Because you need time to kind of make the anti-RH antibodies, but it would still happen. So you would get more of like a delayed. This one would be if this was reversed, like O pause to O neg, you'd get like a delayed. If this is like the first time seeing the positive blood, so it wouldn't happen that same day. This would 100% happen. It really would be immediate if you give type A blood to a type B person. It really would be immediate, but just for intensive purposes of exam questions, it can be up to 24 hours. But usually it's not. Usually it's pretty. Actually, sorry, it's like 1 to 6 hours, I think. But usually it's very quick because again, you have the anti-A in the body already if you're B. And then all of these other ones can be done. So this was a good just kind of review of blood typing. So remember, if you're O neg, if you are RH neg, you can give to both RH positive people and RH negative people. Don't forget that. If you're RH positive, you can only give to RH positive. Because again, this is an antigen. Just think of RH as an antigen. That's why I kind of like D antigen better than RH. Because it's more visual for me. I'm like thinking of like an actual like letter D on the red cells. So if you give that to someone that doesn't have D on their red cells, the immune system's going to be like, this is foreign. Let's make antibodies against it. But if you don't have D on your red cells, it doesn't matter if you give it to someone that has D on the reds. It doesn't matter. Okay? So this is kind of what it's saying. I want to see if it says, no, it doesn't really say, but it's just like, it's everything we kind of talked about. And then I just wanted to briefly go over this again because I think you are expected to know blood typing for this, according to Dr. Milani. So, again, same thing. O negative universal donor can give blood to anyone. No antigens on its, no A or B antigens on its surface, no D antigen. So, technically, you can give it to anyone. AB positive can receive from anyone because they got all the antigens. They got A, they got B, they got D. If you're Rh negative, you can only give to people that are Rh negative. And then depending on what antigens you have depends on if you're AB for, I think always AB is a little tricky because you have to remind yourself you can, like AB, you can give to just A. It doesn't have to be AB to AB. But everything else, it's going to depend on what antigen do they have and then what's their Rh. So you can kind of think of it as like two separate things. So A positive, you can only give to A positive, A negative, O positive, O negative. The negatives can only give to the negatives because if you give it to a positive person, it'll wait, hold on. I'm saying that backwards. Is this chart right? No, sorry. I'm doing it wrong. I'm looking at it opposite. So if you're A negative here, sorry, you can give to positives. So you can give to AB positive, A positive, and you can give to negatives. So AB negative, A negative. And then since you're A, you can give to any cell that has A on it, any cell. So that includes just the A's and it also includes the ABs. But you can't give it to O because O, there's no A. You see what I'm saying? I'm going to stop talking. I think you guys get it. But just keep that in mind. Like if you have A, you can still give to AB. If you have B, you can still give to AB. But if you're AB, you can only give to AB. Sorry, I was doing that chart backwards. I'm sorry. Ignore everything I said prior to this. If you're AB, you can only give to AB. Okay? Because think about it. Just think about it. Just don't even listen to me, but just think about it. Because if you are giving a red cell that has both A and B, but you're giving this to someone that just has A, they're going to make antibody. They have anti-B. It's going to attack the B antigen on here. So that's why AB can only give to AB. Make sense? I actually think this is a very confusing chart. I'm so sorry that I put this on here. But just make your own chart and just kind of remind yourself. I think this was more helpful for seeing the RH, but this is kind of confusing for the, yeah. Okay. Good. Blood typing. Okay. Next. Yeah, you guys are all going to hear me in your head saying, don't get got during the test. No, you didn't. No one has gotten got. Okay, that was 90. If you need more time, let me know, but I'll try to go through this and show you kind of what to focus on. 18-month-old boy, okay. Third hospital admission due to sepsis. That's a lot of hospital admissions for sepsis. So this is with strep pneumonia. So we have a bacteria. Okay, so patient has been having diarrhea today. Doesn't really tell you much, but you can think infectious bacteria. And like an infectious diarrhea would be a bacteria. Multiple infections since 6 months. That's kind of standard with these immunodeficiencies. Okay, so brother died of sepsis at 5. Kind of like they're kind of getting along the lines of like it's another male. This is a male. Patient takes no medications. Okay, meeting developmental milestones. So what does this mean? This means that it is not SCID, because remember, SCID would be failure to thrive. So if they're meeting developmental milestones, this is kind of like a little like a baby buzzword, meaning like not SCID. Like this is there's no failure to thrive here, and SCID usually presents with failure to thrive. Okay, blah, blah, blah. Okay, thin boy, small for his age, fine, but he's meeting his developmental milestones, so I'm not too worried about it. Tonsils are not visible. T or B cells doesn't really help me. Low concentrations of B cell immunoglobulins, but normal T and NK cell counts. Okay, so we got a B cell issue here. Cervical lymph node, no germinal centers. So we have absolutely no B cells here. So then it's like, all right, which one of these is that? And you guys got it. No one got. We got a mutation of Bruton's tyrosine kinase gene. So remember, that's, I guess, what the BTK stands for. Remember, I was like, what does BTK, well, what does the B in BTK stand for? So it is Bruton's, and then the TK, remember, is a tyrosine kinase. Tyrosine kinases, so we chatted about this yesterday. Remember, tyrosine kinases allow for like development, like proliferation of cells. So that's what's happening with Bruton's agammaglobulinemia or X-linked agammaglobulinemia is tyrosine kinase is mutated. So this is mutated. So we don't have proliferation of our B cells. So if you were to look in the bone marrow, it would be like up into a certain point, and then it would stop like the B cell development. So you would stop at like the pre-B cells. So there's absolutely no mature B cells in this patient. So that's kind of the tie-in with like tyrosine kinases. They allow for proliferation. So if you don't have it, you can't proliferate. And the exact opposite of that would be like a cancer that hyper releases, has tons of tyrosine kinases. That's a cancer. That's like a cancer by definition. It's allowing for proliferation. So going into this, everything we kind of talked about, X-linked recessive, that's what the X for is in it. And they said like the brother died. That's like a kind of another indication. Usually it's the maternal uncle, but it's fine. So then everything we kind of talked about. So decrease in all antibody types, recurrent infections after mom's IgG antibody wanes around 6 months. And remember, you can cure it with a bone marrow transplant. Because again, it's an issue with the stem cells of the bone marrow, right? Those stem cells have this mutation. So if we give a different type of bone marrow to this patient, hopefully they can make new hopefully the new stem cells in the new bone marrow will allow for like better B cells, basically. Great job, guys. No getting got. Okay, next. Okay, about 90. So, so I actually wrote this question and I totally understand why teachers find such a difficulty writing questions because it's like you think about everything, right? And then you're like, "Oh, I didn't think about that." But basically what I was trying to do with these answer choices was get at, okay, you didn't have to know that when you get like when you need rabies, like when you need prophylactic treatment of rabies, that you have to give the rabies vaccine, but you also give this rabies immune globulin. You didn't have to know that, but I was kind of getting at like rabies immune globulin is basically like anti-rabies toxin immune globulin. Like it's basically just an antibody against rabies. So that's typically what happens when you get like when you're doing rabies prophylaxis. So the whole idea of getting this immune globulin is oh, sorry. Yes, okay, good. Is to provide short-term protection against rabies. This is your passive immunity. Remember, this is your passive immunity. And remember with oh, actually I'll just show you. I'll just show you the yeah. So I kind of went into like this was my thought process when I was writing this, like writing these answer choices. So with immune globulin, this is just again, it's just antibody. I'm sorry you got. It's okay. It happens to the best of us. So remember with immune, and that's good because like I couldn't. That's why wrote this question because I couldn't find a good one that you like would be at the level that you would need to know. And something you definitely 100% need to know is the difference between passive and active immunity, and like what are some features of passive and active. So one of the ones is remember immune globulin. This is passive immunity. You do not get. It's not active. It's passive, but remember a feature of passive immunity is it's not lifelong. Down here, with passive immunity, you get no memory. So there's no production of memory cells when you give this immune globulin, and there's no activation of B cells. You're not doing anything. You're just trying to kind of bind up the rabies toxin. So kind of, I put back on here this first aid chart just to kind of highlight like it's just kind of important to again it's kind of like the innate versus adaptive charts that you see. Like it's also really important to know this passive versus active chart. Um, Again, I really don't think I don't want to say not to know these, but I really don't think you need to know them first year. I know a lot of us did use this mnemonic for like board studying, so to be healed very rapidly before dying. These are all of the things that you would need to give like immune globulin to after. So I put on here rabies is one of them. It's the rapidly on here. So this basically means if you get tetanus, and a lot of the times it's like a toxin because again when you give the immune globulin you're just trying to neutralize that toxin. The rabies virus, you're trying to neutralize the virus. Okay, so you get these preformed antibodies. It they work right away because they're there already, they're made, but they're very short living, so you don't get lifelong immunity because your immune system didn't do anything. You're not going to get any memory from it. It's just someone just gave you some immune globulin. So this was kind of like um it's not really an example on here. It's not really antitoxin, but it's kind of acting like an antitoxin. It's like an antivirus immune globulin. Okay. But with this down here, you can kind of see like combine. You can do both. You can, and remember, like that's why I wanted to use like a bat because everyone knows when you get, if there's a bat in the room, you wake up with a bat in the room, you should go get checked out for rabies because you won't feel the bat bite. You get the rabies shots. It's like the 5 shots, and then you get immune globulin. Okay, rambling about immune globulin. But does this make sense? So know this chart, memorize this chart, know the difference between the two. It's a very easy question that I can 100% see Dr. Milani just writing something very similar to this and just seeing if you know the difference between the two. Okay, next one. That's okay. You don't have to remember. Just wanted to remind you guys it's a thing. Okay, you guys ready to go over this one? I know it's a little quick. But this is like a classic, like, yeah, you know it, you don't know it, right? You see it, you're like, okay. There's really no like, you know, like there's really no like, thinking. I guess there could be, but regardless, with this, count the lobes, right? You want to count the lobes. So we're gonna count the lobes first. So this looks like 3. This is like 1, 2, 3. Okay, this is 1, 2, 3. All right, so we got 3 lobes. And what are these? These are granules. Cool. So we can take off our agranulocytes, take out our lymphocyte, take out our monocyte. Do these look like basophils? Basophils, remember, thick purple granules. They cover the nucleus. You can't even see the nucleus. No, these are not basophils. These are classically the two that everyone confuses. And so I wish I had like a comparison picture for what the other one looks like. These are neutrophils. So these are your PMNs. Eosinophils look just like neutrophils, which is why they're kind of tricky, but I'm telling you the granules are just going to pop out at you. Go back to that lecture, the peripheral blood smear one, and look at how pink. I know it's hard because it's like they're not right next to it, but these look like really wimpy granules compared to like the bright pink, that's an eosinophil, you know? So just really, again, neutrophils, eosinophils, everyone confuses. So I just wanted to put one on here to remind you guys, like, yeah, these are neutrophils. Count the lobes of the nuclei and look at if their granules are there, and then what color they are. If they're bright pink, eosinophils. If they're bright purple, covering the nucleus, they're basophils. And if they're just kind of like, nah, they're like whatever, that's your neutrophil. Okay, and this little guy is a platelet. These are platelets. This is a platelet on top of a red cell. This is not an inclusion. Remember the inclusions, like it's not a How Jolly body. Remember the How Jolly bodies, they're really dark, dark, dark inclusions. Yeah, this is always tricky when it's like on top of something. But I don't think that would do that to you. Okay, neutrophils, eosinophils. Okay, so again, 3 to 5 nuclei, granulocyte, high presence. And again, if you see tons and tons and tons of neutrophils in the blood smear, think bacterial infection. Or two other things we talked about. One of them, so if you have tons of neutrophils in your blood smear, well, three things we talked about. No, two. Yeah, two. The other one would be like an LAD. So if you have an leukocyte adhesion deficiency, that immunodeficiency, remember the neutrophils are trying to leave the area and they can't leave because they can't bind to the ICAMs. It's like an integrin. It's like LFA1. It's like a specific integrin that these neutrophils don't have. So when they undergo like margination, rolling, like blah, 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 they can't tight bind to the endothelial cells and they can't leave. So the body's like, oh, clearly we need more neutrophils, increases the production of neutrophils, tons of neutrophils in the peripheral blood smear. But you're like, they can't get there. So that's LAD. The second one, glucocorticoids. So we briefly touched on this yesterday. Remember glucocorticoids, if someone is on a steroid, which glucocorticoids are steroids, if someone's on a steroid, it increases it basically causes white cells to like just enter the blood. That's just what it does. It decreases NF-kappa B, but you're just going to see, like, again, it's like something I told you, like, the second years we always do. We're like, oh, maybe they're on a steroid when we see high neutrophils. It's like just something we think about now. Okay, so those are the three things you would really kind of, when you have high like neutrophils in the blood, those are like the three things you should kind of be thinking of. Bacterial infection, like LAD, or like they're on a steroid of some sort. Those are the three things you should think about with like this immuno exam, right? Okay, good. Okay. So this one, I actually don't want you guys to answer this. I just want you to be aware. So this is in Savarese. Oh, we got an answer. So this is in Savarese, and I just want you to be aware that if you're going to use Savarese to study for this, he has a different chart. So I zoomed in. He has a different chart for the ribs with the rib dance. So I don't want you to pick, yeah, so this one would have been quadratus lumborum, right? Because 11 and 12 are your quadratus lumborum. Savarese says 10 and 11 are your lats. 6 through 9 is your serratus anterior, which we learned 6 through 8 serratus anterior, 9 and 10, and then 11 and 12. So don't go off of Savarese's chart is basically what I'm trying to say, because again, you're dealing with Cooley. This is what Cooley taught us. Okay, so this was more so like, don't answer this. Just, I didn't even put an answer for this because it's like, it wasn't the correct answer. He said it's the lats, right? Yeah. So he said lat was correct for this, but we know it's your quadratus lumborum with the rib dance. Okay. The other thing with your rib, your muscle under, when you guys are studying for when you review your OMM, do not get gut. Write this on here. If this says inhalation dysfunction, I don't care if they give you like of ribs 6 through 8. I don't care if it matches up so perfectly with the rib dance exhalation dysfunction muscles. If this says inhalation dysfunction, it does not matter. The answer is the diaphragm. right? So which muscle is used to treat an inhalation dysfunction? It's always going to be the diaphragm. Again, this can be it can match up beautifully. They can give you all the beautiful answer choices with the rib dance. I don't care. Don't get got. She loves to get people with that. I feel like she's going to put that on every exam. She puts that on like every OMM thing moving forward. I think that actually did come up on my complex too. So it's with good reason. But remember, inhalation dysfunctions, the muscle is the diaphragm. That's what you're trying to treat. Okay, good. Just promise me you won't get got with that. With that. Because that's like a you know? Okay. Back to medicine stuff. Thank you. Thank you for promising me. Okay, that was 90. I'll give you guys a little bit more. I think that's what a lot of you guys are having problem with this one. Okay, good. So let's chat. Let's chat. So yeah, so we'll talk about everything in here and kind of like what they're trying to get at. All right, we have this boy. Okay, fine. Presentation, slow bleeding from the cuts, inflamed and exuding pus. Okay. He says that he often gets infections. Okay. For physical exam reveals a thin, extremely pale boy with platinum blonde hair and pale eyes. So what does this kind of make you think of? This kind of should make you think of albinism. So platinum blonde hair is basically like white. It's like white hair. You know, like the trends, like when girls dye their hair like platinum blonde, it's like very, very blonde. That's what they're trying to get at. Like this is not he didn't dye his hair this color. That's his color. It's like blonde to the point of white. And then the pale eyes, and then the pale boy. I also love platinum blonde hair. I'm not making fun of platinum blonde hair. I wish I could pull it off. I would not be able to. I think it's so cool, but this is just saying like the platinum blonde is like he was born with that, which is not normal. Like no one is born with platinum blonde hair. So you can kind of think of this as just being white, and then like very, very pale eyes, and then a pale boy. Albinism. So a lot of you guys were like, this is Shedia Kagashi. But then you're like, I'm looking for an answer having to deal with microtubules. Some of you guys did unfortunately get got with actin. Actin is not a microtubule. Actin and microtubules are two separate things. They're both like involved. It's like actin, microtubules, and then intermediate filaments. Yes, a lot of you guys did, but it's okay. A lot of you guys did. But I'm here to remind you guys about the molecular biology, right? No, I'm kidding. But the three types of like these things in our cells, actin, microtubules, intermediate filaments. Microtubules and actin are different. So this was getting at, okay, which of these processes is involved with microtubules? And remember, one of them is when the lysosome fuses with the phagosome. Remember, it does so by following along a microtubule. So it kind of like, so when we have this is like let's say a dendritic cell or whatever, and it engulfs something in an endosome, and now the lysosomes have to come and fuse. They have to get here via microtubules. So they get here, follow, like literally getting pulled across with a microtubule. So that doesn't work. You don't get phagolysosome fusion formation, and that's why he has tons of, where does it say it? Yeah, he often gets infections that have occurred since his birth. So it's like that's why they can't these phagocytes can't kill what they're ingesting. Make sense? Yes. So when you with your actin cytoskeleton, this is your Wiskott algae. So this is your WAS, and remember that triad. So it's your recurrent infections, which he did have, but no eczema and no thrombocytopenia, like no thrombocytopenia. Okay, and then of course the bullet summary. Patients with Shetia Kagashi will present with pale skin, very light colored hair, recurrent infections. That's the main one. I don't really know about the whole recurrent bleeding thing, um, but regardless, it's like the trafficking of these microtubules, sorry, the trafficking of the lysosomes along these microtubules is your Shedi Kagashi. And then here's also this here. So again, it's the list gene. No fusion of the phagosomes with the lysosomes, and then the patients will have albinism because the delivery of melanin to the different parts of the body that receive melanin also follows microtubules. It's kind of the same process. Formation or fusion? Oh, how did they word it? Formation. Oh yeah. So it's kind of like it's the fusion of the lysosomes with the is it called a phagosome? Yeah. The lysosomes with the phagosomes. So technically, that's a good question though, because technically, yeah, you're not forming phagolysosomes, but the actual underlying reason why is because you have an issue with that fusion. So you can't even form a phagolysosome. Yeah, it's a good question. And then yeah, they could have also mentioned these giant granules. They could have also done that. That would have helped with this, but you see this and then you can kind of like assume and like the recurrent infections, you can be like, okay, this is probably Shetia Kagashi. No problem. Okay, so a question came in about this last one. It's a good question. So it was like, okay, we see something like this on boards. How do we answer it? Because like we learned one method, and then here's Savarese with the other method. Rule of thumb. So when you're board studying, you're gonna see there's a lot of differences between like, which is really unfortunate, but you're gonna see there's differences between like first aid and U worlds, which is not ideal, very not ideal. And then you're up at night, like, what's the answer? So with that, like first aid versus U world, you usually always go with U world. That's like the rule of thumb. With this, you always go with Savarese. So for board studying, you always go with Savarese. Always, always, always. So like for board studying, get rid of the rib dance, just get rid of it, and then we're gonna go with Savarese. But you're not taking boards, you're taking Cooley's test, so we don't look at this. So this on our exam would be the quadratus lumborum. Okay. But I'm sure when you guys get to that point, like the third, like whoever you know is the third years will kind of tell you, like, they'll tell you like little things like that. It's hard. It's really hard when resources vary. It really is. You're like, why can't it just all be the same? The worst though is with like the SGL kids who then get a totally different thing from their lectures, and they're like, oh. So it's an issue when these boards references vary. And what's even more annoying is they could be right. Like the ones that are considered wrong could technically be right, but it's like that's too much of a level of understanding that they don't expect you to know for boards. So this is what you have to go with. It's really annoying. That's kind of what UWorld does. That's like why you tend to go with UWorld over first aid. Okay, next. Look at all you people answering so fast. Yeah, you can tell that this is like a board style question because you didn't need any of the beginning. Aw, guys. Okay, that was like about a minute, but most of you guys, I think most of you guys have answered. So we're gonna chat. So, which of these interleukins is an acute phase reactant? You know what I'm gonna say. I'm gonna say hot T-bone steak. Yeah, so this is IL-6. And remember with hot T-bone steak, the K is for IL-6, and that's just acute. It's just imagine this is spelled with a K. Okay. So IL-6 stimulates acute phase reactant formation. That was it. That was really it. These are the nice ones on exams. You're like, yes, straightforward. Okay. I'm so sorry. It has to be done though. I'm really sorry. Okay, that was about 90. A lot of you guys are like, yeah, I have no idea. That's so fine. I just wanted to. Sacrum is one of those things that you can't kind of leave. So I just wanted to remind you guys it exists. So this answer, and we're going to walk through it like step by step, but this answer is E. Got a whole bunch of different answers from you guys, but it's okay. I think a lot of you guys though, remember that the chest goes first, but we'll talk about it. So remember, it's when you do the up down down up down 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 whatever. Remember the chest is first for all of them. So look for that. Cooley likes to do that. She likes to put chest in the middle, and then the axis on the left, and then the physician on the right. Like she loves to do that. So remember, this is the one that's first though. So with this, let's diagnose this guy. So a lot of you guys sent me the diagnosis, which is good. So remember with seated flexion tests, it's the opposite. So if we have a right positive seated flexion test, that means the axis is on the left. Okay? And remember that's different from the standing flexion test with the innominans. But for sacrum, the seated flexion is on the right. It's a left axis. So on left. So then it's like, okay, what type of diagnosis is this? So a deep right sacral sulcus and a posterior ILA on the left. So on the right, it's deep, and on the left, it's shallow. So you can think of this as like the right side is like swinging around the left axis, which is physiologic. So it's an anterior motion. It's physiologic. This is a left on left. So with left on lefts and with physiologic sacral dysfunctions, remember it's going to be up, or down, down for your physiologic ones. And remember, it's chest first. So remember, she does this. So remember, it's chest first, axis is second, which usually has all the way to the left, and then the doctor's force. So I think of it as like CAD. That's why I said doc, but I always think of CAD. The doc's force, I guess you can do CAP too. The physician's force is the last one. So this one didn't really matter because it's up, or down, down, but it's going to become really important with your non-physiologic. So like left on right, right on left. That's going to matter because it's up, down, or down, up, right? So just remember that. Look for where she puts the chest in the answer choice. You don't want to get one wrong because of that, because it's so silly. So, and then the other thing to remember with these answer choices, if it says right lateral recumbent, that means the patient is laying on the right. Like they're laying in the right lateral recumbent position, meaning the right side is down. So the left axis would be up. and we diagnosed the axis. This is the axis, so this is on left. It's the left axis. So this, since this is up and this is up, this would be an up, up, up answer. So this would have to be axis up. So I think that's what made D wrong. No, not D. Yay, this one. Yeah, B. So that's what made B wrong, because this is saying the axis is down. So if they're laying left lateral recumbent, that means they're laying on their left. So the axis would be down. So this would be down, up, up. Okay. Omem, sacrum. It's okay. You have a week and a half. You guys have a week and a half. Okay, next. Okay, that was 90, but I want you guys to all try this one, because this is a really, I think she would put, because she said like this lab test would also be on there. So I think this is something she would put on there. Give you guys like 15 more seconds. All right, let's talk about this one. Yeah, that is kind of confusing. I also hate when they do this, when they go like RH with the negative, positive. RH, negative, positive. I know, I agree. It's confusing. Okay, so with this one, lots of good stuff here. This ties together a lot of stuff we talked about. So we have a newborn that's clearly ill, clearly hemolyzing. Some things are being hemolyzed. So jaundice, hepatosplenomegaly, like just bad things. Mom said that she had uncomplicated pregnancy, is that the birth of her first child was uncomplicated. So she has been pregnant before. And it was totally fine. Nothing happened. So after stabilizing the newborn, clinician sends a sample of serum. So what's serum going to tell you? Serum, you're looking for antibodies. So that's what's in the serum. So we're looking at a sample of mom's serum, a sample of the serum, which should tell us something about the antibodies. So the lab performs a test by mixing the mom's serum with donor red cells of known antigenicity and then adding anti-IgG antibody. This is what type of Coombs test is this? So we have serum, we're adding these known antigen, like these known red blood cells. We know what's on their surface. So these are your check cells, right? Your Coombs check cells or your Coombs cells. So this is your indirect Coombs test. So they're performing an indirect. You always perform indirect Coombs test on serum. Okay, so they did an indirect Coombs and it was positive. So indirect Coombs test is positive. Remember the anti-IgG antibody? This is that AHG. This is that weird looking thing that just causes all of the things to kind of clump together. So like the one from this cell here, then from this cell here, then from this cell here. So what can you draw from the results of this indirect Coombs test? You can basically say that this is HDFN. Mom is pregnant with an Rh positive fetus. So people that picked E, it's a good one. It is a good one. It's a good one to get got with. But so the mom's first pregnant was with an Rh positive fetus. This is 100% correct. She was. That's what sensitized her to make so during delivery she probably didn't get any RhoGAM. So she delivered, she made anti-RH or anti-D antibodies from that first pregnancy, which is fine. First child was totally fine. But now she probably has another RH positive kid, not an RH negative kid. Because if the fetus when it was developing was RH negative, when it was born, it wouldn't have any of these symptoms. It would be fine. Because remember, with blood typing, you can give wait, you you can give so mom's RH negative and she has an RH negative fetus. So that shouldn't be an issue at all. It's always only an issue if the baby is RH, if the baby when it, well, the fetus as it's developing is RH negative, is RH positive. That's when it becomes the issue. Third pregnancy, can you still give Rogam or is it too late because she already has it? No, you can still give Rogam. You can still do it. And that's why like technically like even if like the patient's like, no, I've already gotten Rogam like the first pregnancy, I don't even need it for my second one. They're like, don't care. They're like, I do not care. You're getting Rogam again. So they basically just that's why I'm saying if you right now are RH negative, you're gonna get Rogam even if it's your first pregnancy because it's just too they don't for that reason they just don't want you to make anti-RH. But regardless, they're just going to give it to you for every single pregnancy because they'd really just it's too much of a risk and it has very much stabilized like this ability. How do they make sure they give it early enough? There's a bunch of ways. So in the third trimester, there's a lot of testing that's done. Again, this is kind of what I did in the blood bank lab. I like tested this like cord blood like every few. It's like you like test it every few weeks or something in the third trimester, and you see how many if mom's blood has any baby cells in there. And then depending on if they do, it like hits a certain threshold. That's when you give the Rogam. And then on depending on how much is how many vials they get. So it's like a thing that they look for in the third trimester. Um, but yeah, it's again only with RH negative moms. Yeah, it's really cool. It's really cool, and it's like cool to see it. Like they just send it to the lab. They're like, all right, like, do we give this mom Rogam yet? And if we're like, nah, like she can still probably do like a few more weeks, then she'll come back and get tested again. But with this, kind of the key for this was remembering the indirect Coombs test. You're testing the serum. So again, and remember, commonly they do this to test, they literally do the indirect Coombs test for this, basically, for this exact scenario. So they take the serum, they add the red cells with known antigenicity, which is just, we know that. These are red cells that have D antigen on it. So if mom has anti-D in her blood, when we add the AHG, we're going to get agglutination, which presents with visible clumping. So in here it said like agglutination, that's your visible clumping. If it was negative, mom wouldn't have anything in her serum. So we add the reagent red cells with the D antigen. Nothing binds to them. AHG has nothing to kind of combine. So you get no visible clumping with that. So no, it would be like agglutination does not occur. And then just a reminder of HDFN. The whole idea of this without ROGAM is remember it's the fetal red cells get into mom's circulation after pregnancy one that causes, plasma cells and memory cells to develop. So the second pregnancy, it like automatically kind of goes in and attacks. And this time it's producing IgG because it's the second exposure. Remember, second exposure, it's IgG. First exposure, it's IgM. And then second exposure with the IgG, that can cross the placenta, and that's why the baby can die, or the fetus can die still within the womb. Okay, cool. Good. All right. Okay, let's talk about this one. So clearly something's going on with this boy. What kind of gives this one away is this right here. So his father and uncle have a paternal uncle have a history of repeated hospitalizations for this upper airway and oral facial swelling. This tells me, like without anything else in the prompt, that this is something genetic. It's something in the family history. So something like an allergic reaction is probably not what's going on here because allergic reactions, they're really not like allergies are not really genetic. Like my again, like I said, my twin brother has none of my allergies. He's nothing that I have. My parents have no allergies. So it's you really don't think like allergies with that. So what's another thing that you can think of is like anaphylaxis, which would be like, severe allergies. And that's kind of what they're getting at with A, an antihistamine, and then F, they're getting at epinephrine. This one, I kind of wanted to show you guys another example of a C1 esterase deficiency, asked in the context of not being started on an ACE inhibitor. But regardless, with hereditary angioedema, I remembered today, with HAE, so this is HAE, um, what you can do is you can give a drug that blocks the bradykinin receptor. So I wanted to remind you guys that this is what's mediating HAE. It's that bradykinin. Um, so so I guess with it's so this is something I didn't even know, which so I apologize. I had no idea that it didn't have to just a lot of the times when you see these questions, it would be after like an ACE inhibitor, like when patients put on an ACE inhibitor. This is a 12-year-old, so you're like, okay, you're not going to put a 12-year-old on an ACE inhibitor. They don't probably don't have high blood pressure, but apparently it can get triggered after some sort of triggering incident. So, all right. But what kind of get I like when I still was reading this though, I would still think like dad has it and the uncle has it. Like this is something genetic rather than just like an allergy or anaphylaxis. Um so down here, trauma, dental work, mental, physical stress. So even physical stress is enough to trigger an HAE like attack. And remember with this, so here's kind of like an image. You don't have to know everything in this. It's just kind of like we kind of talked about this. Remember C1 esterase inhibitor inhibits C1, so it would kind of stop that like the complement cascade from going. But what it also does is it also stops the breakdown of bradykinin, basically. So we have tons of this increase of bradykinin, and then we have angioedema from here. And then remember, this is why we always talk about ACE inhibitors. ACE breaks down bradykinin and also helps break down bradykinin. So if you inhibit it, you get even more, and that's what would be like a flare up of the HAE. Does that kind of make sense? I can let you guys read this. But it's something that I didn't know, so I wanted to put it on here, like to just kind of like remind you guys about this, first of all, and also it's bradykinin is what's kind of mediating HAE, even though it's like C1 inhibitor. It has nothing really to do with complement. Okay, so we have increased bradykinin, which causes the swelling, the massive swelling, and the angioedema. But again, remember she had said she wants you guys to know antihistamines, glucocorticoids, and epinephrine. So though glucocorticoids on here too. Steroids are on here too. Wow. So here's a question with all four, like all three of those in one question. But if you administer, another thing that I kind of keep mentioning, is with HAE, it can sound exactly like anaphylaxis, but then if you give something like epinephrine or an antihistamine or even a steroid, it won't do anything for the symptoms. You kind of need to treat the underlying cause, which is bradykinin, like the increase in bradykinin.
Hey, can you
Yeah.
just, I may have forgotten the mechanism, but the reason I convinced myself it wasn't HAE is because I thought C and D would essentially do the same thing, but maybe
C
like,
and D. Oh, okay. So, so you want, yeah. So angiotensin converting enzyme is ACE. Do you remember ACE helps with bradykinin breakdown? So it's kind of like here's bradykinin, so Brady, and then it would be like byproduct. ACE helps with this. It's just like a weird function that ACE has. So it helps with it like facilitates this process. So if you
okay.
were to inhibit ACE using like an ACE inhibitor, remember they end in pril, but again, I don't think that they would do that. I think it would be something like this, inhibitor of ACE. But it would be something like this for the high blood pressure. Or remember, they would say like has super high blood pressure, was recently started on a new medication. You can like reasonably assume it's an ACE inhibitor. If you inhibit this now, there's nothing to help bradykinin get broken down into its byproduct. So we have like this massive increase in bradykinin, because C1 inhibitor also helps break down bradykinin. So now this is a C1 inhibitor deficiency. So that's why we get like such an increase in bradykinin. So that's what's kind of mediating this process. It's causing that massive vasodilation, but it's usually more like upper extremity and like face. Is that better? Maybe this is better. But it's confusing because like you're inhibiting inhibitors. It's like C1 inhibitor deficiency. It's like you don't have an inhibitor. So what it basically does, this is like showing you a lot more steps that you don't need to know yet. Like you'll get into this like a lot more with hemonc, but you can think of C1 inhibitor helping with bradykinin breakdown, and then same with, well, over here. And then same with ACE. ACE also helps with bradykinin breakdown, like this pathway into the inactive metabolites. So now we don't have this, and now we don't have this if you put them on an ACE inhibitor. So that's why you get massive increases of bradykinin. And
Perfect.
usually,
Thank you.
too, yeah, no problem. Usually too, with the C1 inhibitor deficiency, it's like you can still break down bradykinin because we have ACE. And that's why you really don't see like HAE until you put the patient on an ACE inhibitor. Because then it's like it's too much for, like, there's nothing to break it down now. You just took away both things that could break it down. It's confusing because of because of the names. It's really like the inhibitor, and then the inhibitor is inhibiting the breakdown. Like it's very confusing. Okay. So 455. I think we're gonna do like two more. Let me see which ones I want to ask you guys. And then I'll send you these and you can do them whenever. Which ones do I want to ask you? Sorry, I'm like looking on, I have like a little touch screen like thing, and it shows me the slides. I think I want to do this one. Okay, that was 90. So we have this girl. She comes in, 1 week history of white discoloration of the tongue. Okay, do they scrape off? Like, what's going on here? If we zoom down, yes, easily scrape off. Okay. And she's got thick cracked fingernails. We didn't really talk about that, but it's fine. But when you do the KOH prep, which is the potassium hydroxide prep, that shows you like fungi and whatnot. You see budding yeast with pseudohyphae. Okay, so we got Candida. So this is Candida. But now it's like, what type of Candida is this? Because remember I told you there's 2 cells that you need to get rid of Candida. When in doubt for your exam, Candida is always going to be T cells. Okay, you need T cells to get rid of Candida. So if you're ever like, oh, I forget what you said, T cells with Candida. Okay, so even in this one, it's going to be T cells. Neutrophils, this, remember, is a more systemic presentation of Candida. This is going to be like you have Candida everywhere in your entire body. But the deficiency, like the immunodeficiency or like the immunodeficiency form of Candida, it's called chronic Candida or chronic mucocutaneous Candida, I think it's called. It's really the only issue. It's not like a systemic Candida infection. It's really just the white plaques on the tongue. That's really it. And then also the kind of the cracked finger. We didn't really talk about this, but this can also be present. It's still not a systemic, it's not like everywhere in the body. But again, it's going to be T cells for your exam if they mention Candida. The neutrophils tidbit I kind of told you guys about was more so for boards, but I put it on here. Again, remember T cells, Candida, chronic mucocutaneous candidiasis. That's the immunodeficiency. And then I put this on here. Remember this slide for the immunodeficiencies, like the opportunistic infections. If they have decreased T cells, here's like think of your local Candida infections. And I also put chronic because that's the name of the immunodeficiency, chronic candidiasis. The neutrophil one, the granulocytes, that's your systemic Candida. But again, I really don't. This is going to be like a second year boards thing. I think I emphasized this so much last year because someone brought in a question, was like, you said it was T cells. And I'm like, okay, sorry. It's trying to not overwhelm you. So, but that's why. It's you. So you might see Candida is because of not having neutrophils, but just keep in mind that's a very systemic presentation of Candida. What you guys will most likely see is going to be like the white plaques that scrape off the fingernail stuff. It's called onychomycosis. Onychomycosis. It can be with it or not. But again, oral cavity, like nails, things like that. That's your chronic mucocutaneous candidiasis. Okay. So that's that. Okay, let's do one more because it's been a day. No, don't. Okay, that was 90. Okay. So this, you don't really have to know how to interpret like this serum protein electrophoresis. This is kind of how multiple myeloma presents, but you don't have to know that because it tells you what's going on. So further analysis shows your MHC class 1s are downregulated. And again, I told you a lot of the times in cancer cells, this is what happens. The cancer cells downregulate class 1 MHC. So then it's saying the proliferation of these cells that have downregulated MHC class 1 is usually presented by what type of immune cell? And this type of immune cell lyses abnormal cells. So even if you still weren't like 100% sure about the wording, because the wording was kind of weird the first time I read this, what kind of really helps, and that's why I wanted to do this one last, is it kind of ties in the innate immune system versus the adaptive immune system. So if you're thinking class 1 MHCs, you should hopefully get it down to at least your CD8 positive T cells and your NK cells. These are kind of the two that kind of always either interact or don't interact technically with your class 1 MHCs, right? So I'm actually so glad that some of you guys did pick the one that's not correct, because it's a really good point right here to end on this with innate versus adaptive immunity. NK cells are innate cells. CD8 positive T cells, these are adaptive immune cells. So they basically tell you, yes, exactly. So they basically tell you in this that we're looking for an innate cell answer. You could have answered this question by saying further analysis shows class 1 MHC molecules are downregulated. They could have even just taken this out. They could have just straight up been like, it's taken out. They just say the cell that works on this, that deals with this, does not need to get opsonized, primed, or prior activation. This line, these 3 words, this is telling you this is an innate immune cell. They're looking for an innate immune cell. Remember that innate immune cells don't need to be primed. By priming, they mean like sensitized. Like they don't need to see it first and then they can act on it a second time. Remember, innate cells, they don't need to be priorly activated. They work the same way every single time with every single pathogen. They make no memory. They just act the same way. And with opsonization, this was kind of just like another thing, like saying it's not like a macrophage. So that's not really for innate. I mean, it's not really for what I meant here. Priming, prior activation, without the need for that, it's an innate cell. Okay? So for this would be your NK cell. And remember, NK cells, if MHC1 is present, even if there's an activating signal, remember we talked about this, I think yesterday, this would be like your MIC A/B. These are like your stress signals. Even if they're upregulated, if MHC class 1 is here, it doesn't matter. The NK cell doesn't work. The NK cell only works if with cells that have downregulated its MHC class 1. Okay? And remember, they do this. They release porphyrin and granzyme, which is the exact same cytokines that CD8 positive T cells release, and so forth. And then the markers, CD56 is just a general marker of NK cells. CD16, this is your Fc gamma receptor. So this is the one that's involved with ADCC. So this is not ADCC. This is just the normal function of your NK cells. It just kills. If this signal's not here, but the stress signals are, it'll kill it. But remember, NK cells can also do ADCC with the CD16. But again, I really wanted to kind of end with this to remind you, innate versus adaptive, that's going to be a huge portion of your test as well. So like I was looking for like it's hard to find these questions like that are going to be at the level that you would need for your exam. But this is like a good review. Like remember, the innate immune system acts the same exact way every single time. No memory, doesn't need to get sensitized prior, and doesn't ever need to get activated. They're always working. Okay. All right. Let's end it there. So there's a lot more questions. I don't know how I got through all of those last year, to be honest. Let me stop recording.